Good day, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. It is my pleasure to welcome you today to our first webinar of 2018 and the second webinar in our series on value-based payments. Before we begin, I would like to mention a few logistical items. You will be able to download a copy of today's presentation from the CAQH.org website in the next 24 hours. To do so, navigate to the Core pull-down menu at the top of the CAQH.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation as well as the recording will be found under the listing for today's webinar. We will also send you the slides and recording tomorrow, so you will be able to access the information that we are presenting today. We will also save time at the end of today's program to respond to your questions. You're encouraged to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. Our session today will start with an overview of CAQH Core's work on VBP, followed by our featured presentation on the Center for Medicare and Medicaid Innovation's Comprehensive Primary Care Plus, which is a national advanced primary care medical home model, and as the largest ever initiative of its kind, is a 5-year initiative to improve primary care in America through regionally based multi-payer payment reform and care delivery transformation. I would like to clarify that this webinar will not be covering MACRA or VBP in general, and will be focused on CPC Plus. I would like to thank our guest speaker for joining us today. I will properly introduce her a little bit later in the program, but I would like to thank Dr. Laura Sessums, who is the Director of the Division of Advanced Primary Care at CMMI, for being with us today. So let's get started with today's program with an overview of CAQH Core role and work on VBP from our CAQH Core Director, Erin Weber. Erin?
Thanks, Jessica, and thanks to everyone for joining us today. I think it's really important to just start this discussion with a little bit of background on why CORE was started. CORE was founded as a voluntary initiative back in 2005. The administrative standards for key processes, eligibility, claims, et cetera, were not resulting in the level of automation that the industry had initially envisioned through HIPAA. And it was thought that more uniformity was needed to enable automation on the provider side so that they're having a similar experience across the various health plans that they are exchanging these transactions with. So CORE brought together stakeholders from across the industry, plans, providers, vendors, clearinghouses, and other advisors to develop operating rules, which are really business rules that build on the administrative standards in healthcare to provide a more consistent experience across the industry. And that really gets to our mission and vision today. We are an industry-wide facilitator of sustainable health data exchange, particularly focused on improving administrative processes. CORE was named by the Secretary of HHS as the national author for operating rules for 3 sets named in Section 1104 of the Affordable Care Act, and we're governed by a multi-stakeholder board. So nothing moves forward in CORE without agreement between the providers and the plans that are represented on the board. We see our role really not just as a rule development organization, but also as supporting the industry through all steps in the process. So we research and develop rules, we offer certification and testing, we do education and outreach, we promote adoption and measure ROI. So really seeing that full life cycle of industry development and adoption. To date, CORE's work has been really focused in the fee-for-service arena on those HIPAA administrative transactions. But as we are seeing the industry shift to value-based care and value-based payments, there's an opportunity that we see for the industry to begin addressing some of the operational challenges with this new model in similar ways that were experienced with fee-for-service back when CORE was first founded. CORE is well positioned to support this effort. We have considerable expertise and resources around developing a sound operational system for VBP. We have proven success based on our experience with the fee-for-service operations. The rules have really resulted in improved care delivery and better administrative coordination. And we are, most importantly, a facilitator for the industry and have demonstrated the ability to harmonize practices between providers and health plans with our more than 130 participating organizations. It's really important that the industry come together now to collaborate and apply lessons learned from the fee-for-service space to really energize an effort to ensure that this historic shift from volume to value in the industry continues unimpeded by administrative hassles. I'll talk a little bit more about that in a minute. On the next slide, we see a large transition occurring in the industry right now, although, there's still some question as to whether this is really going to move at the pace the industry seems to expect. But 30 to 50% of providers are reporting that they are currently engaged in VBP, and it's expected that more than half of healthcare payments will be value-based by 2020. But the transition to value-based payments is not without challenges. And in particular, there's opportunities to improve operational capabilities to ensure success. Proprietary systems and processes are being used to implement value-based payments and have introduced some operational variation, sort of unintentionally setting up a scenario ripe for repeating some of the prior mistakes I just mentioned that occurred in the early days of fee-for-service with the administrative transactions. The transition from fee-for-service to value-based could slow if providers encounter barriers that make participation burdensome. So it's really important for the industry to come together now to collaborate and coordinate on operations before these proprietary approaches become entrenched. CAQH has done a great deal of research over the past year and a half on opportunity areas within the VBP space to improve operational capabilities. And this slide outlines 5 areas that really bubble to the top. We did a great deal of research, both primary and secondary interviews, environmental scans, et cetera, to come up with these areas. The first is common data sets. There is a lot of data required for VBP to be successful, but there is still inaccuracies in data and inconsistency in the use of data across different VBP models. So there's a real opportunity for the industry to come together around data standardization. The second area is provider and patient attribution. Value-based payments require patients to be attributed to a provider, but different models are using different approaches to this, which makes it very difficult for providers to manage. So how can the industry come together to streamline that? A similar challenge exists around patient risk stratification. Different approaches are being used, which makes it very difficult to standardize operations. We also saw strong interest from interviewees and research participants in improving interoperability, particularly around technical interoperability, the ability to exchange data, which is also very essential to value-based payments, and also process interoperability, using the same workflows and methodologies to implement value-based models. And finally, quality measurement. There's an overabundance of quality measures, which makes it very challenging for providers in particular to meet reporting requirements for VBP. Next slide. So CAQH Core is working on a report outlining some of these challenges with some recommendations and opportunities for the industry to come together and address these areas. In some areas, Core may lead the effort. In other areas, there are already organizations that have started to address some of this, and Core strongly supports those efforts. We have a call this month with a panel of subject matter experts to review the findings and then we anticipate publishing the report to the industry shortly after that. So stay tuned for more detail on this, these findings soon. Slide 11 gives a timeline for the work that we've done. As I mentioned, we're really focused now on stage 3, building industry awareness around the opportunities to improve the operational components of VBP, both through this educational series. This is the second in an ongoing series that throughout 2018, and also through the report. And ultimately, we will be launching a advisory group within CAQH core to look at those opportunity areas that I just mentioned and some of the recommendations that are included in the report, and identify how the industry can come together around some best practices or common approaches to create some uniformity in addressing some of these challenges. So with that, I'll turn it over to Jessica for our first polling question.
Thank you so much, Erin. And as Erin just mentioned, we've launched a webinar series on value-based payments, and we'll continue that series throughout 2018. And what we would like to do with our polling questions is get a little bit of information from you in order to provide better content for future webinars. So let's go to slide 12, and let's go ahead and launch the poll. But we are trying to find out a little bit of, what the knowledge level of our audience, what our audience is already doing on value-based. So the question is your organization actively working on VBP models and strategies? And there are 4 options. Yes, we are actively implementing value-based models. The second option is yes, we are actively designing models for implementation. So maybe you're in a different phase. Third option is no, and the fourth option is unsure, perhaps because a different part of your organization is working on this and you're not immersed in it on a day-to-day basis. So let's pause for a few seconds and collect some information, and then we'll go ahead and share the results. Okay, so maybe let's share the results with the audience. So, Erin, I'm curious to hear what you think about these results, but what I see is it's really interesting that there's a very low percentage of people saying no. So our audience is engaged at various levels on this, and then there's about a third of our audience who is not sure. And again, I suspect that it's because a different part of their organization is working on this, or maybe their organization is very specific, working in other parts of healthcare. Do you have any different?
No, I think that's great insight. I mean, there's more than a quarter that are actively implementing as we speak, which I think makes the work that CAQH core is looking at doing even more critical and timely for the industry.
Agree. Well, thank you so much for that information. And so let's get on with the webinar. So I'd like to introduce Dr. Laura Sessums, who is our featured speaker for this webinar, who is the Director of the Division of Advanced Primary Care at CMMI. She's been in that role since 2013. At CMMI, Dr. Sessums works on the Comprehensive Primary Care Initiative and is actively engaged in thinking about new models for care delivery and payment in primary care. Previously, she worked in academic medicine as a clinical educator, mostly at Walter Reed Army Medical Center as a civilian, where she served as the chief of the general medicine section. Her professional activities have been in the areas of healthcare policy and advocacy, as well as medical education, senior medical administrative leadership, and scholarship at the intersection of law and medicine. Her research has focused on primary care, particularly ethical and legal domains. Dr. Sessums is a general internist and former lawyer and remains an associate professor of medicine at the Uniformed Services University of the Health Sciences. Welcome, Dr. Sessums.
Thanks, Jessica, and so glad to be here joining all of you today to talk about the Comprehensive Primary Care Plus model, which I talk about and think about all day long. So it's great to talk to a different audience about the model. And just to clarify, as Jessica said, or Aaron said, I can't remember, we are an advanced alternate payment model, and I'll talk about how that works sort of towards the end of my presentation. But first, let's go over an agenda to get a sense of what I'm going to be talking about today. I'm going to give you a bit of a model overview, and some of this will focus on things that, as well as the practice transformation activities and supports that are perhaps a little bit further afield of the work that CAQH normally does, but I think it's important to understand the theory of action and construct of the model, so we can then talk a bit about the operational sides and other things that may be things that are more in line with what all of you attending the webinar today normally work on. And I will do some focus on the payment aspects and data redesign towards the end of the talk. So moving on, let's talk about what is the point of this model. And with that, what's sort of the problem we're trying to solve? And I think anybody who's been to the doctor, particularly a primary care doctor, understands some of the problems that we are trying to address with this model. And that is, you get in to see your doc and you're there for a short time. It's hard to get care outside of that visit. You may have questions about your care or your medicines, and information is just difficult to get outside of an actual visit. Some of the services are expensive. If you see a number of specialists, it's hard to get care coordination. And so those are the problems we see that are tied to, though not completely due to, fee-for-service. And thinking about where we wanted to go as we were developing and conceptualizing CPC Plus, we started with the end goals of care delivery, how we see the promise of primary care realized through empowered practices, making clear changes in care delivery and patient engagement. And then we decided how we might support that through payment, quality metrics to which the practices would be subject, and data sharing. So then we designed the model to support and incentivize the sort of comprehensive, patient-centered primary care we think clinicians want to deliver, how they were taught to take care of patients, and that patients deserve to receive. So next slide. In addition to the changes to care delivery and Medicare fee-for-service payment, another cornerstone of CPC Plus is engagement and alignment of a majority of payers that ensure patients cared for by each of the primary care practices in the model. So what does that mean? We think that true comprehensive primary care is possible only with the support of multiple payers, and without that, practices are distracted or frankly overwhelmed at times by the cacophony of all the different payment incentives and quality measurement programs that each payer might be asking for, as well as having insufficient resources for their transformation. We had a previous model called CPC, or CPC Classic as we now call it, where we found that practices that had less than 40% of their practice population covered by payers in the model did not have sufficient resources to make the kind of transformation efforts we were asking them to do. So in CPC Plus, CMS partners with payers that share Medicare's commitment to strengthening primary care through alignment in payment and in quality measurement and in data sharing with practices. And we align with all manner of payers who might be interested in joining us: commercial, self-insured, Medicaid, et cetera. We don't open CPC Plus, or we didn't, to practices anywhere in the U.S. Instead, we used the interest of payers that are willing to align with us to choose the CPC Plus regions. And then once we had identified payer partners and solidified the regions, we chose practices within those regions. And we postulate in this model that the alignment across payers drives change not only at the practice level, but also at the regional level. Because if you have a sufficient density of practices engaged in this model of care. Next slide. So where are we? Where is CPC Plus? As I noted, the regions were selected based on the locations and alignment of payers that submitted proposal to us, and where we found sufficient interest from multiple payers who are willing to align. At this point, we are now in 18 regions across the country. 14 of those regions, shown in blue on the slide, launched in 2017, so it began January 2017, and then we have 4 new regions in green that launched this month. And mostly they're all whole states. So the whole states, to run through them quickly, are Montana, North Dakota, Oregon, Colorado, Nebraska, Oklahoma, Hawaii, down there in the bottom, Arkansas, Louisiana, Tennessee, Ohio, Michigan, Rhode Island, and New Jersey. And then we have some smaller than state regions, and those are Greater Kansas City region, Greater Buffalo, the North Hudson Capital District region of New York, Greater Philly, and a little bit of Northern Kentucky. That's part of the Ohio region. So we cover a broad swath and really go coast to coast in the model. Next slide. CPC Plus is, as I believe Jessica mentioned at the beginning, America's largest ever initiative to transform primary care. And really at its core, it's a test of whether changes in payment and care delivery can improve quality of care and decrease its cost. It's a 5-year model for both tracks, or for both cohorts, both 2017 and 2018. There are 2 tracks in the model for practices based on their level of transformation experience. We have overall, between the 2 different start years, we have nearly 3,000 practices participating with thousands of clinicians caring for nearly 2 million Medicare beneficiaries, but untold numbers of other patients. This is a practice level transformation. So we're not asking practices to just change the way they do their work for Medicare beneficiaries or for just Medicare beneficiaries and those insured by our payer partners, but instead to transform their practice overall. For the way they care for all their patients, whether they are insured by payers participating in the model or not. We postulate that this makes it possible for practices to do the work in a consistent way, and trying to do things differently for each individual insurer makes it very difficult. So in CPC Plus, we have partnered with nearly 60 payers. As I said, these are national payers, regional payers, state Medicaid agencies, et cetera, to provide practices with aligned payment, provision of data for quality improvement, and for measurement of quality of care. We've also partnered with over 55 health IT vendors to work directly with practices to advance the health IT functionality for primary care that we absolutely know they need to do this work, and to optimize on the ground the use of health IT in the primary care practice. Next slide. So as I mentioned, practices in CPC Plus are in one of 2 tracks. And in terms of numbers, they're pretty much evenly split between the 2 tracks, with just a few more in track 2, which is the more advanced one. In track 1, practices are in earlier stages of transforming to deliver team-based primary care and learning to focus on the health of their practice population as a whole, as opposed to just that individual patient coming in front of them for a visit. In track 2, practices generally have more experience with transformation that they've brought to the model and are working on increasing comprehensiveness of the care they deliver, improving the care of their patients with complex needs, creating an inventory of resources and supports to meet the patient's psychosocial needs, and working with their health IT vendors to build the necessary functionality to deliver this care efficiently. I didn't say this on the slide, but there are, we allow practices to participate in SSP ACOs, Medicare Shared Savings Program ACOs, and just under half of our practices are also in the SSP ACO models. Next slide. I'm going to take a minute to go through the work the practices are actually doing, because I think it's very helpful to understand this even at a high level, to then dive into sort of the work in the background that we're doing to support the practices. So we've organized the practice work into 5 primary care functions or corridors of action that help guide their care delivery transformation. And these functions, as you can see, are access and continuity, care management, patient and caregiver engagement, planned care and population health, and then comprehensiveness and coordination. These functions apply to practices in both of the tracks, though the track 2 practices do additional work in each function compared with track 1 practices. Now, I'm going to walk through these functions in a little more detail. So this slide and the next one go through the care delivery requirements for the first 2 model years and for practices in both tracks. So there's a lot going on. But at a high level, our care delivery requirements are intended to provide a framework for practices to build on. And these requirements, which do change incrementally each year, guide practices through the primary care functions as markers for regular measurable progress towards the CPC Plus aims of improving quality and decrease cost. Again, the track 2 requirements include but build upon those in track 1. And so the track 2 includes additional requirements that will help practices increase the depth, breadth, and scope of care offered, with particular focus on their patients with complex needs. So starting with function 1, which is access and continuity. As you can see here, the track 1 practices shown in blue in year 1 worked on empanelment, 24/7 patient access, and assigned care teams. And then starting in year 2, they're beginning to work on measuring continuity of care. Track 2 practices worked on all of those things in year 1 and also worked on coming up with alternatives to deliver care outside of traditional office visits. So this could include things like e-visits, phone visits, group visits, home visits, and or alternative location visits. And I want to just clarify what empanelment means, because that is confusing to many of our practices. That is practices determining who is in their patient population and then assigning those patients to particular providers or to care teams. Under care management, practices are working on risk stratifying their population, and we ask practices to do risk stratification from a clinical perspective. They are not required to use the risk stratification that we or other payers do for payment purposes. So this is clinically based risk stratification. This year they'll be working on doing this in a 2-step way, one using an algorithm and then an overlay of clinical intuition to either add or subtract patients from particular risk tiers. They're asked to work on care management, follow up with patients from after ED visits and hospitalization. And then those in track 2 are working on care plans for high-risk chronic disease patients. Given that we've had a number of practices working on all this from year 1, I can tell you that to date, they're doing really well on 24/7 access, and our track 2 practices have already been working on measuring continuity. For many, empanelment was a new activity, and they're gearing up and have been making progress throughout the year. In terms of function 2, practices are making progress on risk stratification and hospital and ED follow-up. That can be difficult because of inability or delays in communication with facilities, but they have had some more experience with targeted care management, and that seems to be a lighter lift for them. But overall takeaways on these two functions is practices are learning how to identify their practice population and be proactive rather than reactive in terms of addressing health issues in their population. Going through the rest of the functions in the next slide, in function 3, comprehensiveness and coordination. So to clarify, comprehensiveness can be confusing, but in the primary care setting, it refers to the aim of practices meeting the majority of its patients' population's medical, behavioral, and psychosocial needs. And it sort of builds on the element of relationship that's at the heart of effective primary care. The things that practices have been working on are identifying using our practice data feedback that I'll get into in a bit. They're high volume and high cost specialists and working with facilities to improve timeliness of notification. Track 1 practices will be working on collaborative care agreements with specialists and starting to plan for behavioral health integration. Track 2 has already been working on collaborative care agreements and will start working on comprehensive medication management. And they will further their work in addressing psychosocial needs, and they will continue their work in behavioral health integration and practice capabilities to treat patients with complex needs. In terms of that work, I think behavioral health integration is a real struggle for many. It's an area of active learning throughout the model, but one we think is extremely important as primary care gears up to think of itself as a place where patients' behavioral health needs can be identified and addressed, at least in part. Patient and caregiver engagement. We think optimal care and health outcomes require patient and caregiver engagement in the management of their own care and frankly also in the design and improvement of care delivery in the practice. And we require for both tracks, patient and family advisory councils. For many practices, this has been a scary requirement and a very new concept. So there's been a lot of I guess, angst about it, but most have now geared up and had their first PFAC, and we're getting the results of that now. In year 2, 2018, the first year starting practices in track 1 will work on self-management support and deepening that capability, and in track 2, they will begin to work on advanced care planning with some of their patients. And finally, the last function, plan care and population health. This is where participating practices are organizing their care to meet the needs of the whole population they serve. And we ask them to do this through reviewing utilization reports and their own generated electronic clinical quality measures to help improve the quality of care they deliver. And track 2 practices are to have weekly team meetings to go through the data. And to date, practices are making good progress using payer reports and electronic clinical quality measures for quality improvement. So we're pleased with what's happened to date in the care delivery. Next slide. But we know that transformation to a team-based, population-focused, proactive primary care practice cannot happen without supportive health IT. And we learned in that prior model, CPC Classic, that health IT is necessary but not very available to do the work that primary care practices need to do. So we have health IT requirements in this model. There are the sort of basic ones that apply to both practices are the adoption of certified health IT for electronic clinical quality measure reporting. And we do require that all of our practices have that functionality, and the functionality has to allow them
to report for a continuous 12-month period at the practice level rather than a group tax ID number or individual NPI level via certified health IT. And that's fairly unique in terms of other quality payment programs. So you won't see other models going this far as we think into the future of reporting to date. We did slightly relax our health IT requirements for 2018 to align with the quality payment program final rule. So participants can continue to use their 2014 edition cert throughout the year, but we expect that practices will complete their upgrades to 2015 edition cert during 2018. Oh, and I'm sorry, that's the next slide. Yes, so this is, I didn't say that, I apologize. So again, the sort of basic health IT for both tracks is focused on the electronic clinical quality measure reporting. Next slide. In terms of our partnership, though, we've partnered with over 55 health IT vendors who have signed MOUs to support our Track 2 practices. I think you need to go back one slide. Oops, I'm sorry. I've gotten confused. This is the Track 2 slide. So the 55 vendors range from bigger names you all know, Epic, Cerner, NextGen, Allscripts, eClinicalWorks, but also include smaller module-based vendors who are building new software for value-based payment redesign. And CPC Plus aims to empower primary care practices in working directly with our vendors to implement the best solutions that meet the practice's needs. During the 2017, practices have been working on the first 3 requirements, and those are risk stratification functionality, functionality for patient empanelment to a practitioner or care team, and the electronic clinical quality measure reporting at the practice level. And all of these functionalities need to be implemented fully within the practice's health IT workflows. Starting in 2018, this year, and thereafter, practices will be working with their health IT vendors to further develop and implement social needs screening and full interoperable patient-focused care plans to guide longitudinal and high-risk care management. Later on in the model, we're going to be testing and implementing a patient-reported outcome measure. There is not currently a patient-reported outcome measure for primary care, so we're working on developing one. And health IT vendors will support this effort through helping practices document and track patient-reported outcomes. Next slide. We know practice transformation is more of a fundamental change than a quick fix. And I think you can see that by all of the things we're asking practices to do. This is a lot of work, and it is hard work, but can be really transformational and ultimately freeing for practices. But we know they need support going through the process. So we provide a learning system, and our payer and vendor partners are also welcome to participate in the learning system and to track changes practices are making in care delivery and, of course, in the outcomes of the model. So while the learning system is adapting to stakeholder needs and changes over time, it has a couple of core platforms. One is the CPC Plus practice portal, and this is where practices report quarterly on their progress on care delivery redesign. And then our learning faculty can target learning for practices based on gaps and challenges that reports from this, that the reports we create from the reporting practices do can reveal. CPC Connect, it should say CPC Plus Connect, is a web-based platform where all of our stakeholders can share ideas, best practices, and resources, and it's kind of like a Facebook for primary care transformation. We've had a lot of activity on this site, thousands and thousands of posts and documents and downloaded, etc., which is very gratifying. And then lastly, the learning communities, which include robust webinars, learning faculty coaching, virtual and in-person meetings. And these communities promote collaboration and engagement within and across our 18 regions and the 2 tracks, as well as coordinate the learning nationally. Next slide. So this slide says opportunities for practice and payer engagement, but it really should say opportunities for payer engagement. And it's really to give you a flavor of how payers can engage in the work of the model, both through activities designed for payers and those designed for practices. Payers have a regional table that they are in charge of where they can meet together, either with or without a convener, to discuss alignment with the model goals of payment, quality measurement, and practice data feedback. And each of our payer partners have signed a memorandum of understanding about how they intend to align, but it's hard to do that. And in a region, they want to align both with us and with each other. There's a number of national payer tables. We have CMS-led webinars to talk about the model and the work the payers are doing. There's also a group through the Healthcare Learning and Action Network, the Primary Care Payment Action Committee, where payers can meet virtually as well as in person at the annual LAN Summit to talk about the work they're doing in CPC Plus specifically in their own plans. And then the Milbank Memorial Fund engages our conveners generally and some of our payers in a multi-state collaborative meeting to talk more. They talk at a national level about the work at the region. Payers are also invited to participate in our national webinars and all of our regional events. There are some practice-facing events at the regional level where payers are strongly encouraged to participate, to understand more clearly the work going on in the practices and develop a dialogue with the practices. And then they work with our data aggregation contractor, Deloitte, if they are interested in working to aggregate data at the regional level for practice feedback. So now I'm going to talk about payment, which is, of course, extremely important and a foundational element of this model. So the payment is, I'm going to talk here about the Medicare fee-for-service payments, but remember our peer partners are aligning their payments similarly. There are really 3 parts of the payment, and each of the tracks has 3 different parts. So going across the top, there's a care management fee, which we pay quarterly, prospectively, per Benny per month payment. There's a performance-based incentive payment, also per Benny per month, which we pay annually in advance. And then there's some ways that we're redesigning the underlying payment structure. The care management fee in track 1 averages about $15 PBPM. For track 2, where we pay for the additional work we're asking practices to do, it averages $28, but can range up to $100 for the most complex patients. The performance-based incentive payment is a modest award, $2.50 PBPM for track 1, $4 for track 2, and it rewards practices' improvements of quality of care and impacts on utilization. We do not pay this to practitioners who are dually participating in a Medicare Shared Savings ACO, since that would be duplicative of the shared savings loss initiatives in that model. But we do pay it to all of those who are not participating. And then finally, our payment redesign structure. We don't do anything different to underlying fee-for-service for track 1, but in track 2, we introduced a hybrid payment where a portion of expected evaluation and management payment is prospectively paid and paired with commensurately reduced fee-for-service payments. And the goal of this payment is to offer more flexibility in the setting of where care is delivered and to reduce dependence on visit-based payments and, frankly, on volume. So next slide, how do we determine who gets paid for what under the per Benny per month? Well, this is a look at our attribution methodology. And we make all three of our payments for patients we attribute to practices using the prospective claims-based attribution methodology, which we do each quarter. Obviously, for the incentive payment that we pay annually, we only do it once a year. But we run attribution quarterly, and with a 2-year look back, we identify beneficiaries who have received primary care services from a given practice. Beneficiaries who received the majority or the plurality of their primary care services at one practice are attributed there. We also ensure that no practice is sharing a beneficiary with other models that share savings unless it's an SSPACO. And we do allow, as I said, some of our practices, nearly half, are also in an SSPACO. And then we, I guess it's important to point out that because we're a practice level transformation, we are attributing beneficiaries to the practice site rather than to individual practitioners or solely to a tax identification number. As a result, we have to pay a lot of attention to who is in that practice, which practitioners are a part of that practice. And when a practice tax ID number or NPI composition changes, the CPC Plus practice updates this information through the CPC Plus practice portal, which we then verify and vet, and once vetted, can use thereafter in attribution. So now for a little bit more detail on the 3 payment types. And I'm going to start with the care management fee in the next slide. It's a non-visit-based payment to practices for each of their attributed beneficiaries. And as you can see on this slide, the care management fee is risk-adjusted, and we use HCC scores, or hierarchical condition categories. And the risk tiers, they're tiered relative to the regional population. Track 2 payments are higher to account for the more advanced care delivery work expected of them for each of the tiers of patients. But we have divided the top quartile from track 1 and split off the top 10% of high-risk patients and are paying $100 PBPM for patients that are in that top 10% of HCC scores, and we've added to that dementia diagnoses, since we know those are prevalent in the Medicare population, and HCC scoring does not currently account for dementia diagnoses. Note that there is no beneficiary cost sharing for the care management fees. Next slide. In addition to the care management fees, we pay a performance-based incentive payment to all CPC Plus practices not in an SSPACO. We give it at the beginning of the year and measure performance over the course of the year. Based on their performance, though, they are at risk, and they can either keep none, some, or all of it. The payment's divided into 2 components, one based on quality, one based on utilization. Half of the amounts that are paid to practices are based on the CAPS patient experience of care survey and on the 9 CPC Plus electronic clinical quality measures. If they do well on quality, they're eligible to keep that half, and as well as the other half, which is based on 2 utilization metrics, emergency department visit numbers and inpatient hospitalization. Next slide. Finally, we're moving track 2 practices, as I said, away from fee-for-service using a hybrid payment. And it has 2 parts, the comprehensive primary care payment and the reduced fee-for-service. The comprehensive primary care payment, or as we call it, the CPCP, compensates practitioners for clinical services that are traditionally billable, but it offers flexibility for them for these services to be delivered inside or outside of an office visit. And we're trying to get to something we think of as incentive neutrality, where a practice would be agnostic as to whether they deliver a service in person or via another modality. And in this situation, care can be delivered according to clinical and patient preferences and not driven by fee-for-service billing. We calculate the CPCP as a percentage of expected Medicare payments for evaluation and management services to attributed bennies. And then we reduce evaluation and management services billed during the program year by the percent that we've prepaid in the CPCP. In the first year, practices have had a choice between receiving 10%, 25%, 40%, or 65% upfront in their CPCP. And in later years, over the first 3 years of the model, they then transition to either a 40% upfront or a 65% upfront. Next slide. To be able to keep their incentive based on quality, practices need data so that they can understand the quality of care they're providing, improve it, as well as reduce its cost. And through CPC Plus, practices have access to a fair amount of data. They get attribution and payment data quarterly, which is included in the CPC Plus practice portal. They get quality data in their own EHRs. They have electronic clinical quality measure data that they can use regularly for quality improvement, and we require them to do that. We also field CAPS surveys, patient experience surveys, annually, and provide them that information annually, so they can use that to continue to improve patient experience and align that with the PFACs that they have in their practices. Some of our regions are pursuing multi-payer data aggregation. In 3 of our existing regions that carried over from the prior model, CPC Classic, we are continuing data aggregation there, and that is in Ohio, Oklahoma, and Colorado. This allows, of course, clinicians to view data across their population rather than from the individual payers, and we hope to improve that number over time in this model, so it will have more regions engaging in data aggregation. And then finally, in our practice data feedback that we give to all practices, whether they're in a data aggregation region or not, we provide information on cost and utilization. And I'm going to go through that in a little bit more detail because our data aggregation and data feedback is unique. So in terms of data aggregation, this slide gives you a little bit more detail about how it works, kind of a high level, a little bit more detail. But the various payers in a region who are participating in data aggregation give a claims line feed to the data aggregator who has been chosen by the payers in that region, and we join that choice once it's made. They then compile, the data aggregator compiles and standardizes the data, analyzes it, and reports it with comparative measures and other drill down capabilities. It's then reported back to providers to inform their practice transformation and improvement work. In the case of the data aggregation, as well as the individual practice data feedback that I'll go through in a second, practices have the opportunity to drill down from the practice level to the individual patient level, which we think is really important. So next is a screenshot of our practice data feedback reports, and this is just Medicare, currently in Excel format. And we share this quarterly with our practices. It displays claims-based information on their attributed beneficiaries, including demographics of the practice and the bennies, expenditures and trends, utilization trends, and some information on quality and specialty use by their patients. We are continuously developing this report to make it as user-friendly and actionable as possible for our practices, and working now to transition from an Excel-based format to an online tool that will update practice data on an even more frequent basis. Next slide. Finally, because this is about alternate advanced alternate payment models, let's shift gears to discuss how MIPS alternate payment model clinicians and advanced APM qualified professionals are paid while participating in CPC Plus. Note that as I go through this, I'm talking about CPC Plus practices that are not in a Medicare Shared Savings Program ACO, because those practices will have their MIPS eligibility or an advanced alternate payment model eligibility determined based on the track of Medicare SSP ACO that they are in. So first, in terms of MIPS eligible clinicians participating in CPC Plus practices that are not exempt from reporting to MIPS will benefit nonetheless from the APM scoring standard because they are participating in CPC Plus. And CPC Plus is a MIPS APM. These eligible clinicians only have to report separately one MIPS category beyond what they're already reporting to CPC Plus. And in addition to their CPC Plus payments, they will see a MIPS payment adjustment that occurs 2 years after their performance year. So they will see a 2019 payment adjustment based on their 2017 performance. For those practitioners in CPC Plus practices who are determined to be qualified professionals, and by the way, that's the vast majority of CPC Plus clinicians in 2017, they're excluded from MIPS adjustments and receive a 5% lump sum incentive payment. As with MIPS, the payment adjustment occurs 2 years after the performance year is over. As you see here, this is a timeline of how these payment adjustments play out. And I know it's complicated, but the MIPS payment adjustment in payment year, looking at 2019, for example, is only plus or minus 4%. But as you go down through the years, by 2021, that reaches 7%. So on one hand, participation in MIPS could get you an even higher adjustment than if you were a QP in an advanced alternate payment model. But if you aren't a QP and you don't meet MIPS thresholds, you could see your payments cut by 4% in 2019 or up to 7% in 2021. But even if you're subject to the MIPS adjustment, the special APM scoring standard is meant to reward participation in the alternate payment model, CPC Plus in this case, and thus makes it much more likely that you will receive a favorable payment adjustment under MIPS. So that's what I have today, and would certainly be happy to take questions and appreciate your interest in CPC Plus.
Thank you so much, Dr. Sessums. That was a really comprehensive presentation, and we really appreciate you taking the time to be with us today virtually. We're going to take a quick polling question, and then I do think we will have time to take a couple of questions. So this next polling question, and let's go ahead and launch it in the interest of time. But we'd like to know what topic is of most interest for our next webinar. We want to be receptive to what the needs of our audience are. So please let us know, would you like, and this is a select all and that applies. So you can click all of them if they're all of interest to you, but would you like to see an overview? Would you like the next presentations to focus on some of those opportunity areas that Aaron talked about earlier on in our presentation, such as interoperability, patient risk stratification, provider-patient attribution, and quality measurement? So let's keep this poll open for a few more seconds, and then we'll share results and go quickly to Q&A. So let's go ahead and share the results. It looks like an overview is what we will cover during our next webinar, followed by interoperability and quality measurement are topics that are of more interest than the other two, even though patient risk stratification and the attribution topic do have a high number. So thank you very much for that feedback. And then we do have time to answer a couple of questions. So Dr. Sessums, there were several questions from audience members who were interested in engaging in CPC Plus. Is this a closed program, or are there ways in future years to get involved?
I very much appreciate the interest. And unfortunately, at the moment, CPC Plus is closed. We had 2 different periods where we sought payer and practice proposals, and now we have closed. We remain open if there are vendors who are working with practices and want to join as a vendor partner. That is still available.
Thank you. And then there was another question for you, Dr. Sessums, regarding behavioral health. And you mentioned that there were some challenges in some primary care physicians where taking a little bit longer to build that into the program. And does that have to do with the HIPAA privacy laws, or are there other reasons why behavioral health is a challenge?
That's a great question. I think for the SAMHSA rule that deals with substance use disorder privacy, that has been a bit of an issue, but I think way bigger than that right now is the availability of behavioral health specialists who can be available in a practice and work with practices to deepen their capability to address behavioral health problems. And then further, there's some substantial differences in the way different payers pay for behavioral health, and some use a carve-out. That means those patients are only able to be cared for by certain practitioners, and the payment can be quite low, and it's difficult to get patients into those providers or to have them collaborate with our practices. So there's a lot of very structural systemic issues that have caused problems so far.
Thank you for that answer. And hopefully, as the years go by, some of those parity issues and access to the right specialists will be less of an issue. So we are out of time. I'd like to thank you, Dr. Sessums, as well as our audience for participating with us today. In slide number 40, we've got a couple webinars coming up in the next few months. We hope you will join us and register. And then finally, in the last slide, here are some ways for you to engage with us. And we want to thank you very much for taking the time out of your day to join us. Have a good afternoon.